Over to you, Dr. Neha, Dr. Amit, and Dr. Shashi.
Thank you, sir.
We can start the live streaming anesthesia. Once we are live streaming is on,
good evening, everyone. I welcome you all. Good evening, everyone. I welcome you all to this another session of Knowledge, Attitude, and Practices in Anesthesiology, KAP series. This is the second series of P20 series, which is the Private Practitioners Forum, where we have interesting presentations from private practitioners across the country. Moving on, I would now like to invite the coordinator of this session, Dr. Sunil Sethi, sir. Dr. Sunil Sethi is a consultant anesthesiologist at Work Hospital, Karnal. His major achievements include he is a faculty at national and zonal conferences, organized state conferences, Haryana state conferences in 2019. He is a Proficiency Award recipient ISACON 2021, past Secretary ISA Haryana, past President ISA Haryana, and his areas of interest are labor analgesia and critical care. Good evening, sir. I now invite you to speak a few words.
Thank you very much, Dr. Neha, and it's a privilege to be on this platform, national platform of knowledge, attitude, and practices. And I see a great vision in the eyes of Dr. Naveen for ISA National, and I don't know where he gets the energy to have these ideas. Every time he has a new idea, and he's working for all the generations. It is not like youngsters. It is for everyone, whether it is a private practitioner, whether it is in the government job, or medical legal issues, or issues pertaining to postgraduates. God bless him, Dr. Naveen, and it is rather privilege to have Dr. Badresh Shah from Ahmedabad, Dr. Rajiv Gupta, Dr. Shashi as part of this private practitioner series. Last time we had a very good discussion, and it was the discussion was so long that we had to apologize to the rest of the speakers, among them Dr. Tyagi, Dr. Girish, and everyone. It is very difficult to stop in between, but the discussion was so interesting, and we see today also that the enthusiasm remains same among the delegates and participants, and this group is having so much of discussion that you need and you learn so many things every day with so many academicians, so many practitioners. I wish all the best to the KAP series and see you soon. Thank you. Thank you, Neha.
Thank you so much, sir, for those enlightening words. It sure indeed is a very interactive and very helpful session for all of us. Moving on, I would now like to invite the brain behind this series, Dr. Naveen Malhotra, sir. We welcome you, sir. Naveen Malhotra, sir, is a senior professor and head in Cardiac Anesthesia Department and Pain Management Center in PGIMS, Rohtak. Sir, major achievement, as he always says, dear ISAs relate to him as our own secretary, and I know all of us who work with him, who've been attached with him, can feel that, sir, is just one of our own. He is an ISA Bhopal Award recipient for Academic Excellence in 2015. He also has the KPR Young Anesthesiologist National Award in 2009. KOP Award recipient in Critical Care in 2001. Sir has a whopping 216 publications and 426 presentations under his belt. His areas of interest are cardiac anesthesia and chronic pain management. We welcome you, sir. I would like you to say a few words.
Thank you, Dr. Sethi, Dr. Neha, and Dr. Shashi for those kind words, and welcome to the session 2 of the P20 series, which is a dedicated series for private practitioners and who are doing exceptional work in periphery single-headedly. That is the most important thing, because they have got minimal or no support at times. And in institutes, we know that we have support of our colleagues, postgraduates, and OT technicians, so on and so forth. But they are doing excellent cases, excellent clinical work with great skills. So they are putting into their action their knowledge with a good attitude to serve the mankind, and they've got exceptional skills in which they are managing the cases so brilliantly. And that is why this idea came up, why not to have presentations from private practitioners so that they can share their knowledge, wisdom, and skills with us. And so this series is dedicated to the private practitioners. And yes, last time it generated so much of discussion that we couldn't control the discussion, because the discussions are the key. Delivering a lecture is one thing, but interacting with our colleagues all across the country is the second thing. So I'm very happy that we've got another 4 speakers today, and we will continue and have total of P20, like G20, we're having P20. Thank you very much. Over to you.
Thank you, sir. That really is very enlightening actually for all of us. I would now like to invite Dr. Shashi Bhanana, who's also the coordinator for this KAP Academic Series, to take forward this session. Over to you, Dr. Shashi Bhanana, ma'am.
Thank you, Dr. Neha. I will just share my screen.
Dr. Shashi, can you hear us?
Yeah. Very good evening, everyone, and a very warm welcome to Knowledge, Aptitude, and Practice Session 2023. So it's my privilege to extend my warm welcome to all the coordinator and the chairpersons and the presenters over here.
Can you please near the mic?
Hello.
Slightly increase your volume, please.
Okay, sir. Hello. Am I audible?
A bit better.
Yeah. I would like to invite our first chairperson of the day, Dr. Rajiv Gupta, sir, who is a HOD of Department of Anesthesia and Interventional Pain Management, Maharaja Agrasen Hospital, Delhi. His major achievements include being a Governor Council member at ISA National, past Secretary of ISA Delhi, and fellowship in interventional pain management, faculty at many national and international conferences. His area of interest includes difficult airway interventional pain management. We welcome you, sir. Hello. Am I audible?
Please continue.
Yes, ma'am. Please continue, ma'am.
We welcome you, sir. Dr. Rajiv Gupta, sir.
Please continue, Shashi. Invite all the chairpersons.
Okay, sir. Okay, we welcome Dr. Ramakrishna Reddy, sir, who is a professor of anesthesia at Medicity Institute of Medical Sciences, Hyderabad. His major achievements include MD and DNB examiner, and he has got total of 12 publications under his cap. He's an invited faculty at ISACON Telangana State and various other conferences. He's a quiz master for PG Golden Con quiz at ISACON 2018 Agra and ISACON 2019 Bangalore and ISACON 2022 Shillong. And he has been quiz master at various conferences. His ISA activities include being Honorable Secretary at ISA Telangana State, recipient of ISA Proficiency Awards 2022. His area of interest include labor analgesia and critical care. We welcome you, sir.
Thank you, Dr. Shashi. Thank you, Dr. Naveen, sir, and Neha, Dr. Sethi, sir, for giving me this opportunity in this prestigious academic session. Dr. Naveen, sir, is a trendsetter in academics, ISA academics. Thank you.
Welcome, Dr.
We welcome you, sir.
Thank you, sir.
Now, please welcome our final and third chairperson of the day, Dr. Bhadresh Shah, sir, who is a chief anesthesiologist at Pokraj Hospital, Ahmedabad, Gujarat. His major achievements include being a past secretary at ISA Gujarat, past secretary ISA Ahmedabad City Branch, organizing secretary ISACON 2021 Gujarat, and organizing secretary Golden Jubilee State Conference of Anesthesiologists Society. His area of interest includes regional anesthesia and mainly parasclerosis. We welcome you, sir.
Thank you, Sasi, and thank you, Neha, for conducting this series nicely. And as my dear friend Sethi said, Dr. Naveen sir is really trendsetter in his asset of ISA. He really boon for all of us. And sir, we are really enjoying your academics and all your activity of ISA. God bless you, sir, and thank you all.
Welcome, yes, sir.
Thank you.
Welcome, you, sir. Now, without further delay, may I now invite our first presenter of the day, Dr. Girish Kumar, sir, who is a senior consultant anesthesiologist at Cygnus Institute of Gastroenterology. His major achievements include TS Judah, General Secretary 2012 onwards. He's a runner-up at Race Quiz SRMC Chennai, former medical superintendent at Cygnus Hospital, Hyderabad, and a governing council member at Hyderabad City Hospital and Telangana, founding member of treasurer of ISA Telangana, and first interceptor rider at Ladakh 2020 and Ladakh 2019, Mustang Valley, Nepal 2022. His area of interest includes critical care, ultrasound in critical care, regional anesthesia, onco anesthesia, and obstetric anesthesia. We welcome you, sir. Over to you, sir, now. Dr. Girish.
And Dr. Girish, sir, please unmute yourself. Right, so you can start sharing your slides, sir.
Yeah, just a second. You're able to see my slides, sir?
No, sir, please start with the PowerPoint presentation again.
Yeah.
Yes, sir, that's all.
Yes.
And please click on the full screen.
Yes, sir, it is visible now.
Please start, sir.
Good evening, everyone. I am very thankful that KAP Academics have given this opportunity, and I am also thankful to Dr. Naveen Malhotra sir, Rajiv sir, Ramakrishna Reddy sir, Shah sir, and Sethi sir, Shashi ma'am. After speaking to Sethi sir, I came to know about KAP Academics and the importance of it in daily practice in peripheral anesthesia. So he asked me to select a topic which will benefit the peripheral anesthetist. So I came up with this stress-induced cardiomyopathy, which most of the peripheral anesthetists will be unaware or will be in the coming days, they will come to know after coming across my topic. So today we are going to deal with stress-induced cardiomyopathy. Coming to stress-induced cardiomyopathy or Takotsubo cardiomyopathy, the name is derived in 1983 by Japanese anesthesiologist after seeing the ballooning of apical portion of left ventricle in a form of Takotsubo, which is nothing but a octopus catching pot. So here we can see the apical part of the ventricle, which is supposed to be conical, has ballooned out to look like a Japanese Takotsubo cardiomyopathy. So we are not supposed to confuse this with peripartum cardiomyopathy. Peripartum cardiomyopathy, here patient will be having last trimester or immediate postpartum, patient will be having peripartum cardiomyopathy. Whereas in stress-induced cardiomyopathy, it can occur at any time. Duration of symptoms generally insidious and long standing in peripartum cardiomyopathy, but in stress-induced cardiomyopathy, a normally functioning heart suddenly fails. So it is a drastic fall of the cardiac functioning of a normal heart in stress-induced cardiomyopathy. Recovery may or delayed recovery will be there in post-peripartum cardiomyopathy, but usually recovery is rapid in stress-induced cardiomyopathy, and patient will improve their ejection fraction 20 to 25% in a course of 3 to 4 days. Troponin is not elevated, whether it is modestly elevated in stress-induced cardiomyopathy. Echo features are dilated left ventricle, hypokinesia, and classically, initially, stress-induced cardiomyopathy was named after the dilatation of apical part. So most commonly, apical part is involved, but rest of the left ventricle can and usually stressors are present in stress-induced cardiomyopathy. So stressors, as an anesthetist, if we come across, so what kind of stressors the patient will face to land up in stress-induced cardiomyopathy is acute blood loss, general anesthesia with hypoxia and stress, spinal anesthesia with fluid overload, or pulmonary edema. So general anesthesia and spinal anesthesia both can cause stress in different ways, resulting in hypoxia and stressing the heart, resulting in sudden cardiac failure. And along with this, especially in LSCS and DNC, the patient might receive the IV ergotamine, methyl ergotamine injection soon after sedation, and prostaglandin is also one of the cause for stress-induced cardiomyopathy when used in PPH. So as an anesthesiologist, when and where we can encounter this Takotsubo cardiomyopathy or stress-induced cardiomyopathy, they can, as I said, it is in most commonly in perioperative period. Other places is like diagnostic and non-surgical minor procedures like electroconvulsive therapy, dobutamine stress echography, then electrophysiological laboratory studies, or interventional radiology, catheterization, and endoscopy. Acute trauma cases where there is aneurysm of subarachnoid aneurysm, or acute CNS condition like subarachnoid aneurysm, pheochromocytoma, sepsis-induced cardiomyopathy, allergic reaction resulting in enormous amount of adrenaline release in the body may cause stress-induced cardiomyopathy, and exogenous epinephrine administration. So generally, there are two types of stress-induced cardiomyopathy. The one is primary, and the other is secondary. Primary is stress is associated most commonly emotional outside the hospital. So as an anesthetist, we most commonly see secondary Takotsubo cardiomyopathy, which happens in hospital setting, which we have previously discussed, like from perioperative region till exogenous epinephrine administration. So Takotsubo often presents like an acute coronary syndrome. Patient will be absolutely fine before this stress. The patient will be having good ejection fraction, and after that episode of stress, suddenly patient's left ventricle fail. So nearly fail. So it can present in various forms. Like generally, adults will be having more predilection to Takotsubo compared to pediatric. Females are having more risk compared to male, especially in perioperative period. Risk factors are like emotional, physical stress, perioperative period, critically ill patient. So pattern of wall motion abnormality, classically it was described as apical, but later on midventricular, basal, and inverted part of the left ventricle are also involved. So importance of pathology here is like generally when there is a stress, our body will secrete a flight or fight hormone like adrenaline. So this adrenaline will be acting on adrenergic receptors. So generally, depending upon the distribution of adrenergic receptors on the left ventricle, various parts of the left ventricle can be involved, like apical, midventricular, basal, or inverted. So whichever part of the left ventricle in that particular individual is having maximum number of adrenergic receptor, that part will be involved first and maximum. So in pathology, what will happen after that involvement, intrinsic adrenergic receptors are activated during the stress, there is excessive epinephrine, norepinephrine causing cyclic AMP mediated overload or intermitochondrial calcium and excessive contraction. This excessive contraction will result in damage of the cardiac damage, which is direct damage, and indirectly there will be an ischemia of microvascular dysfunction. So this ischemia will cause the ECG changes and raise in troponin. So depending upon the density of the distribution of the beta adrenergic receptor, the part of the left ventricle of that particular individual will be involved. So other factors, what are the other factors? As I said, females are more involved. So estrogen receptors and emotional state of the patient, depression and antidepressant drugs, and pre-existing endothelial dysfunction are the major risk factors. Clinical course and complication, many patients recover without complications. Generally, 50% experience some complication. So if the crux of management is early recognition, Early recognition is possible the moment patient says, I am having SOB, or moment patient says, I'm having difficulty in breathing. The moment we hear these two words in perioperative period, we have to first catch, okay, we have to auscultate the patient's lung. If there are minimal creps, we have to get 2D echo done. If there in the 2D echo there is fall in ejection fraction with no history of previous cardiac condition, we have to alert ourselves that we are dealing with nothing but a stress-induced cardiomyopathy. And believe me, this is very common situation which we will skip. Mostly when once the patient says that patient is having SOB, patient is having creps, we will give Lasix or diuretics, some or the other diuretics, and patient will recover from that without diagnosing further what was the cause for pulmonary edema. So generally, most of the patient, around 50% of them, without being diagnosed, the patient had a stress which resulted in Takotsubo cardiomyopathy. Without diagnosing it with the diuretics, generally we will clear the fluids and decrease the load on the heart, so that heart will improve the functioning. So in due course, without diagnosing, we are treating Takotsubo cardiomyopathy in most of our peripheral setting. So serious complications are like congestive heart failure, pulmonary edema, cardiogenic shock. Other complication can be mitral regurgitation or LV outflow obstruction, sudden deaths, mural thrombosis. All these can be diagnosed with simple bedside 2D echo. And arrhythmias. Arrhythmias can be diagnosed anywhere with this thing, what you call ECG. Coming to diagnostic criteria, Mayo Clinic US has given a criteria of Takotsubo cardiomyopathy, which says that there is a transient hypokinesia, akinesia, or dyskinesia of left ventricular mid-segment with or without apical involvement. And there will be epicardial vascular, there will be no single epicardial vascular distribution. Generally, in myocardial infarction, there can be generally single heart vessel will be involved, but in Takotsubo cardiomyopathy, it is generalized situation of the whole left ventricle or apical part of the left ventricle. So there will always be a stressful event, and new ECG abnormalities like STT changes, left bundle branch block, QTC prolongation, etc. And modest elevation of troponin and anti-proBNP. Anti-proBNP is generally in terms of around 2000 or more. Absence of obstructive coronary disease or angiography evidence, acute plaque rupture, etc. This is possible only after once the patient recovers and we take them to cath lab. Absence of pheochromocytoma or myocarditis. The myocarditis, we can get it done with MRI or pheochromocytoma with blood investigation. Coming to management, as I said, the crux and importance of the management is early diagnosis. So early echo is most important, wherein we can find LV function abnormality, mitral regurgitation, LV outflow obstruction, and mural thrombi. These all things can be found, and in MRI you can definitely have diagnosis of myocarditis and mural thrombi. Generally, it is treated at the basic level like an acute coronary event, wherein patient can be given a blood thinners, antiplatelet drugs, AC inhibitors, beta blockers, and dobutamine diuretics or vasodilators. Vasoconstrictors can be required when there is drastic fall in left ventricular function and associated with sepsis, and mechanical supports like BiPAP or invasive ventilation can help in reducing the respiratory stress caused by pulmonary edema and all. And mechanical circulatory supports like IABP and ECMO can be used as a last resort. So coming to risk stratification, European Society of Cardiology, here they have given that at least a patient should have one major or two or more minor risk factor to suggest that a patient is having low risk for Takotsubo cardiomyopathy. High risk patient in ICU is supported by the complications. Generally, will be having more major risk factors. The coming to, as we have topic pertaining to LSCS and DNC. So generally, systolic blood pressure here, major risk factor what we need to concern is systolic blood pressure having less than 110 mm of Hg. Clinically, pulmonary edema will be there, ejection fraction less than 35, outflow tract obstruction greater than 40 mm of Hg, mitral regurgitation, apical thrombosis. So all these things can be diagnosed with bedside monitor and a bedside 2D echo. Coming to the minor risk factor, QTC prolonged greater than 500 milliseconds, pathological Q waves can be seen, STT segment elevation persisting greater than or equal to 3 days, BNP greater than 6 picogram, and NT-proBNP greater than 2000 picogram are minor risk factors which are particularly important in pregnant patients. Thank you.
Thank you very much, sir, for your valuable insight on the topic. So, first, if anyone have any questions, they can type it in the chat box. Any questions?
And over to you, Chairpersons, for the discussion, sir. Dr. Kadresh, sir, Dr. Ramakrishna Reddy, sir.
Yes. I understand. Congratulations, Dr. Girish. Well presented. And it is a rare syndrome, but if it is encountered in private practice, it is very stressful for the anesthetist as well. So, in your, what do you suggest? Relatively spinal or GA if this patient comes for obstetric surgery?
Sir, both spinal and both GA can cause stress-induced cardiomyopathy. What we require is, as the ISA says, eternal vigilance is cost for safety. So if a vigilant anesthetist is there, sir, even in spinal and even in general, patient can be diagnosed early and to avoid the complications, sir. As I said previously also, the moment patient will develop pulmonary edema without diagnosing the condition, a perioperative clinician will be giving a Lasix. So in that way, most of the Takotsubo cardiomyopathy unknowingly will get treated and patient will not be diagnosed as Takotsubo and patient will recover unknowingly to a clinician.
If already diagnosed stress cardiomyopathy patient presents for cesarean section, is it better to go for GA rather than spinal?
Sir, stress-induced cardiomyopathy is an acute condition, sir. So if a patient already under stress and coming as a primary Takotsubo cardiomyopathy, a patient will be having pulmonary edema definitely. So if a patient comes with the Takotsubo cardiomyopathy or any other cardiomyopathy, general is always better than regional anesthesia.
Yes, because they are already on anticoagulants and so many other things. And to control the things also, having a endotracheal tube and GA is better, I think. Thank you.
Thank you, sir.
So there is a question in the chat box that whether you have experienced this case of stress cardiomyopathy in your practice.
Yes, ma'am, I have experienced 4 times this stress-induced cardiomyopathy. I'll try to tell you one incident wherein one of our teammate in one other hospital where I was, my team was working, they called me, patient after giving DNC, dilatation and curettage, patient suddenly having chest pain and we had to intubate the patient. So I ran from my one center to the other center. When I went across, I came across these people who are NRIs and they resisted for simple ECG and chest X-ray in a PAC, saying this is not required for DNC. So what happened is, I don't know, with God grace on the same exact time I was able to reach there. We had already my colleagues had intubated the patient. So we shifted the patient to ICU and put her on ventilator for, I think, 5 days she was on ventilator. She was obese, young female, white female. After 5 days, she recovered. And I think on 14th day, we had coronary angiography done, which was normal. Only then we told them that patient was having Takotsubo cardiomyopathy. This is my first incident. After that, in LSCS, 2 LSCS, in other hospital where my team was not working, they called me saying that patient is having a difficulty in breathing post LSCS on 2nd day. When I went there, patient was having pulmonary edema. This patient we couldn't save because patient was not ready to get treated at our ICU. They wanted to have a higher center. So they wasted their time from taking from our center to the other center. So patients didn't survive. What I said earlier, early treatment is crux. We don't treat early with diuretic and other stuff. the patient will not recover. And most important thing here is like if an inexperienced critical care person comes across Takotsubo cardiomyopathy, they will not think about the urine output. They will just think about the vitals. If blood pressure is falling down without even there is compromise in the urine output, if they keep the patient on NORAD or any other inotrope which is acting on beta adrenergic receptors, it will deteriorate the patient condition. So if most important thing in Takotsubo cardiomyopathy here is because it is stress-induced cardiomyopathy and it is secondary to the endogenous adrenergic secretion which is acting on the adrenergic receptor, we have to avoid as much as possible the inotropes and get the maximum out of patient with what you call urine output should be monitored. And if it is required, if there is a compromise or raising lactate, there is circulation deficit bulky, if you are able to document, only then inotropes should be started. And generally patient will be having tachycardia and hypotension both together. So if that hypoperfusion, there is adequate perfusion of the heart, drastically we should not decrease the heart rate. We have to go for, rather than going for a beta blocker, we have to go for like evaporating tablet. I don't think evaporating injection is available. Evaporating, which will not decrease the ejection fraction but will decrease the heart rate. So initially if we can decrease the heart rate and maintain the perfusion, immediately within 2 to 3 days patient will start recovering. And as I said, initially pro-BNP and troponin I will raise, but pro-BNP will raise only after 6 to 8 hours. We will be able to see that pro-BNP is beyond 2000. Initially, before 6 hours, the pro-BNP will not rise more than 2000. Only with 2D echo, you will be able to see there is ballooning of the left ventricle and a patient is having pulmonary edema. That lab report diagnosis will be possible only after 6 hours.
Okay. Thank you very much, sir.
Sir, there is one more question in the chat box.
Ms. Anita Cooley wants to ask, has the incidence of cardiomyopathy increased after COVID?
By my personal experiences, madam, after COVID, I have encountered more number of arrhythmias, more number of on-table syncopal attacks. This is my personal experience. After COVID, I have found more number of arrhythmias, more number of syncopal attacks on the table after spinal anesthesia.
Okay. Thank you very much.
Shashi, there is another question in the chat box by Dr. Muthukumar. One was about the COVID. Other was hopefully it is diagnosed after exclusion of other cardiac conditions. So Dr. Girish, what do you say? Is it a diagnosis of?
Sir, can you repeat the question, sir?
How do you diagnose it? Once again, they want to know that how you come to the diagnosis of stress-induced cardiomyopathy.
Stress-induced cardiomyopathy. The most important thing is patient will be having good ejection fraction without any cardiac symptoms previously. One stress episode will be there, where either it is emotional, then it will come under primary Takotsubo. Secondary Takotsubo is the condition which, as an anesthetist, we will generally encounter, wherein hypoxia, combination of hypoxia and tachycardia. Hypoxia and tachycardia will be resulting in dilatation of the left ventricle and decreased ejection fraction, which is transient. That transient fall in ejection fraction can be corrected in 3 to 4 days of time if we decrease the stress response, relax the patient, put them on ventilator, decrease the pulmonary edema, increase the oxygen saturation, and decrease the stress. So it is a acute thing. Patient will be having 1 hour before, patient will be having good ejection fraction. After 1 hour, after that stress, either it is due to general anesthesia or spinal anesthesia, within 1 hour, patient will be having decreased ejection fraction. Patient will be landing up. It's an acute episode of acute coronary syndrome like feature, wherein patient will be having pulmonary edema within 1 hour or 2 hours or 6 hours perioperative. So patient will not be having any previous history of cardiomyopathy, but latest now patient will be having all symptoms of heart failure.
Dr. Girish, just 1 minute. Dr. Girish, as you described very well that we private practitioner label it as an impending failure, and we are using Lasix and IRAP position and oxygen, everything for regional. Now, my question is there any role of steroid to prevent or to decrease this stress response? Steroid is helpful or not?
Sir, there are no studies I have come across which will say that steroids will decrease the incidence of Takotsubo cardiomyopathy. They have no studies.
Okay.
So there's one
Most
more
important
question
thing
from
is preventing hypoxia, sir. Hypoxia prevention, hypoxia and tachycardia. These are two vicious combination which we should avoid.
Okay.
Right. So one more question from Dr. Muthu Kumar. They want to know that if milrinone or levosimendan are preferable in such situations.
Ma'am, the thing is like inotropes drug of choice. Generally, theoretically, if we go, it is levosimendan. We can theoretically prefer, but only for one patient we have used levosimendan. Rest of the 3 patients who are admitted in our ICU, we have improved the cardiac foundation only with dovitamin. So levosimendan is not non-adrenergic inotrope. So generally, people say that levosimendan is better than adrenaline or noradrenaline. Generally, French people will be preferring adrenaline, and other people will be using noradrenaline for all hypertensive conditions. But here, both noradrenaline and adrenaline, dopamine especially, are having drastic effect on the heart because they will act on adrenergic receptors. So along with auto adrenaline or endogenous adrenaline, we are increasing the adrenergic receptor stimulation with noradrenaline and adrenaline, so dopamine. So we will try to avoid these inotropes, and levosimendan can be preferred only if patient is having sufficient insufficient perfusion. Only then we will go for inotrope, and if levosimendan is available, it is better option.
Right, fair enough. So we welcome Dr. Rajiv Gupta, our chairperson, and final chance to Dr. Himanshu. If you want to ask, you can unmute yourself. Okay, done. So over to you, Shashi, for introducing the next speaker. And I must place on record sincere thanks to Anesthesia TV and Mr. Rahul Chaube for being the media partner and live streaming it across YouTube and Facebook. Thank you, Anesthesia TV.
So without further delay, we would like to invite Dr. Priyal Gupta ma'am. She's a consultant anesthesiologist at Shri Sai Hospital, Muradabad, owner at Dr. Raghu Child Care Center. And her major achievements include gold medalist at MD KGMU and executive member of Muradabad City Branch, ISA Muradabad City Branch. Her area of interest includes neonatal and pediatric anesthesia and pediatric airway management. We welcome you, ma'am.
Thank you so much. Am I audible?
Yes, ma'am.
Yes, ma'am.
I'm sharing my screen. May I start if this is visible to everyone?
Yes, ma'am.
Yes, ma'am. Please go ahead.
Good evening, everyone. I am Dr. Priyal Gupta, and I'll be discussing anesthetic implications in gastric pull-up surgery in an infant. So let's begin with the PSC. This particular child is a 1-year, 2-month-old male, a case of congenital esophageal atresia. He was posted for the surgery of gastric pull-up. Now, this child had already undergone an esophagostomy and gastrostomy at birth under GA, for which he had required ventilatory support for a week. Now, when the child had presented for this surgery, the weight was 15 kgs. As you can see in the picture, the child is quite chubby, the neck is short. So obviously we had planned for difficult intubation, but these children, they have esophagostomy done at the neck. So continuous salivation is there. So that can cause a difficult intubation scenario. But in this patient, we did not encounter that. For investigations, it is very important in this children to take a good history, because this particular anomaly, it can be associated with other bacterial defects. This complete esophageal atresia is type A of the tracheoesophageal fistulas that we see, and it is only 8% of the occurrence is only 8%. So it's a very rare case, and therefore we have to do a pediatric cardiology evaluation in these patients. A 2D echo and ECG must be done to rule out any cardiac anomalies. We should know the preoperative hemoglobin. In this child, it was 14. But this surgery, it takes around 3 to 4 hours. So we have to plan whether we need any blood transfusion or not, although it is minimally blood loss surgery, but it is better if we keep 1 unit cross-matched. very important thing to be considered here is it's a very high risk procedure. Mortality rates up to 20% have been reported. There is a high rate of morbidity. Survival rates can be very low. So it is very important to counsel the patients, parents. Parent counseling is very important. It is not a one-day thing. It has to be done over a period of time so that parents can understand the procedure, the post-operative management, and the home care that will be required in these patients. So now I will discuss pre-medication. Pediatric anesthesia pre-medication is very important. I will discuss a very generalized schedule that I am following. As of now, I am conducting 30 to 40 pediatric cases per month. And this is a generalized schedule that I have been using. We do a lot of daycare surgeries. So firstly, I explain a 4-hour NPO to the parents, and mostly the milk is advised 4 hours before we proceed for the procedure. An IV cannula is placed at the time of admission by a competent NICU or PICU staff, and if required, a blood sample is sent simultaneously. So what happens is the child comes, he is admitted, a cannula is placed, sample is sent simultaneously. Within 2 hours, we receive the reports, and if everything is fine, we move ahead for surgery. Till then, the child is with the parents. So in this case, I am able to minimize fear related to the surgery, separation anxiety, because here not only we have to elevate the fear and anxiety of the patient, we have to even look after the parents as well, because the parents' fear is also there. And these are the 3 drugs which I use in IV dosing, as mentioned here, before taking the patient in the OT. That is midazolam glycopyrrolate, and in some older children, IV ketamine in low doses of 0.1 to 0.5 milligram per kg is also used. Let's discuss about this particular surgery, the gastric pull-up. As you can see in this picture, the stomach has been mobilized and it is being pulled up into the mediastinum. It is done in a pure or long gap esophageal atresia. In this, we also do, the surgeon also does a feeding jejunostomy. I'll explain why that is done later. 2 things to be noticed, as I have said, that it's a procedure which has high mortality and high morbidity. Mortality rates up to 20% have been reported. And because there is mediastinal handling, the stomach is pulled up and the anastomosis is made at the neck with the esophagus. So because of this mediastinal handling, there can be intra and post-operative tachyarrhythmias, which can be a cause of mortality and mortality rates. So for induction and monitoring the normal monitors I have used. For temperature, here I would like to show the child is lying on this orange mattress. This is an electric mattress where the temperature can be set. It is very useful in cases of neonates and infants where we can maintain adequate temperature. We often forget temperatures in adults, but in children it's of utmost importance, and this is almost a 4-hour procedure, so hypothermia should not be there. For induction, I normally go with a combined induction of propofol and sevoflurane and fentanyl and atracurium. Then for maintenance with fentanyl, atracurium, fluid management again is important. This procedure had lasted for almost 3 hours. Foley's catheter was placed, urine output monitoring was done, fluid calculation maintenance according to the holiday cigar formula, but one also has to be vigilant because there is stomach handling, and the procedure is long, so vital monitoring, urine output monitoring, and everything else is required. Balanced salt solution is preferred here. Dextrose containing solutions are mostly preferred for neonatal surgeries. Now, as I've talked about these arrhythmias, the drug that I have used here is injection esmolol. I will discuss about this. Now, you can see in these pictures on the left side, the stomach has been mobilized, pulled up into the mediastinum, and on the right side, you can see the anastomosis is being done in the neck. Now, I will discuss the role of beta blockers here. This study, as you can see on the left side of your screen, this was performed by a group of pediatric surgeons and anesthetists in Lady Hardinge Medical College, Kalavati Saran Children's Hospital, where they have talked about 2 types of procedure done in these patients of pure esophageal atresia. In this particular study, they have mentioned esmolol as a drug used to manage these arrhythmias. So the dosing they have described is 250 to 500 microgram per kg per minute IV bolus over 1 minute, followed by an infusion dose of 50 mic per kg per minute, which can be increased to 300. So this particular dosing I have used in this patient. Intraoperatively, 2 doses, bolus doses were required when mediastinal handling and anastomosis was being done. And postoperatively, I had used continuous infusion for 2 days. Post-operative care, obviously in this patient, we'll go for an elective ventilation without, will not give a reversal agent, but the patient is not kept relaxed. The patient is kept sedated using midazolam and fentanyl infusions, along with other painkillers like diclofenac and paracetamol. Now, injection esmolol was used in the doses as described before. And sedation and esmolol, it was given for at least 2 days and it was weaned after 2 days. Child was extubated on the 4th postoperative day. Even after 2 days of finishing the infusions, bolus doses of fentanyl and esmolol were needed up to the 4th postoperative day. Now, this X-ray might seem a little weird. You can see a nasogastric tube coiling in the mediastinum. There is some chest congestion, but this is a good X-ray for this child because the stomach is now in the mediastinum acting as the esophagus. On the 8th postoperative day, this study is done. This is the dye study where you can see contrast opacified stomach in right paramedian hemithorax region, showing a normal distal passage of contrast in bowel loops. At first glance, this might seem an alarming X-ray, but this X-ray is good because the dye has passed and the anastomosis is working. Feed is now started. Child is discharged on 10th postoperative day after a successful dye study. Here what we see in this picture, the child, for the first time, the child is taking anything from his mouth because since birth, the child was not able to feed anything. And for the first time, the child is taking orally and the feeding tracheostomy is maintained so that the parents can slowly wean to oral intake and the parents have been tutored on the needful. And here we see the child having an oral feed for the first time. We also published this particular case in the newspapers, local newspapers. And as you all know, our anesthetists are usually in the background, so surgeon is taking up the limelight. Thank you so much for patiently listening to me. We did this case in 2018. This child has been a regular follow-up of ours and he is 6 years old now and perfectly healthy right now. Thank you.
Thank you very much, ma'am. There is a question from Dr. Rajan. He is saying that 4-hour starvation for milk is not advisable. It should be 6 hours and 4 hours is for breast milk only.
Yes, protocol-wise it is that, but in practice I have seen that 4 hours is sufficient. Till now I have not encountered any aspiration problems and mostly I'm doing cases in daycare. So 4 hours is absolutely sufficient in practice as of now. And I am mostly doing cases in iGel. That is, I'm using a supraglottic airway device. And till now, I have not encountered any aspiration problems in such with the 4 hours NPO.
Thank you, Dr. Priyal. I will now invite the chairpersons to start with the discussion. Over to the chairperson, sir. Any questions, Dr. Vidresh sir, Dr. Ramakrishna Reddy, Dr. Rajiv Gupta sir?
May I add, Dr. Neha?
Hello?
Dr. Neha?
Yes, sir, please.
Am I audible?
Yes, sir, you're audible.
Yes, it is.
Yes, sir.
You're audible.
Very wonderful presentation, and I must appreciate the efforts by Dr. Priyal. And definitely, one must differentiate in practice that adults and pediatrics are two different things. A person who, like you, if you are doing you are practicing pediatric anesthesia, many things are to be kept in consideration. And it is very good that you have to maintain temperature. Temperature is the core success for pediatric anesthesia. And along with that, you said balance out solutions. It should be very clear that we are using balance out solutions or the fluids containing dextrose, because people are in trouble when they don't maintain the temperature or they don't maintain blood sugar also.
Yes, sir.
And you're very well done and very well presented, and it is very knowledgeable. Thank you very much.
Thank you, sir. Thank you so much.
Real, you presented very nicely. Now you are conducting so much pediatric and neonate cases. So my question is, which one is the best intranasal, transnasal sedation? Can you highlight a little bit?
Sir, I have not used intranasal or transnasal sedation as of now. if I'm going for monitored anesthesia care in like small cases like abscess drainage or like prepucioplasties or just a release of phimosis, mostly I'm using IV ketamine in the doses as I've described in the premedication part. So, and if we are maintaining that 4 hours NPO, I am getting good results with that.
Okay.
There is one more question, ma'am. Dr. Vaishnav wants to ask whether diclofenac can be used safely in this age group.
Yes, that is a question I was anticipating. I was also not very much comfortable in using diclofenac in these age groups, but may I tell you one thing, that the pediatric surgeon here is my husband actually. So, and we have started our own center and we have been functional for 6 months now. He has been using these high doses for a long time. And now working with him, I have realized that we have not seen any complications till now. I used to use at the in the doses of 0.5 milligram per kg, but he uses as much as 1 to 2 milligram per kg as well. And that also thrice daily in a TDS dose. So till now we haven't seen any complications, but what now I have made a criteria that I use diclofenac above 1 years of age. I do not use it below 1 years of age.
Okay.
Thank you very much, ma'am.
Any questions from Rajesh sir?
The question is there whether diclofenac suppository is better or not.
Yes, we have used diclofenac suppositories also, but it is difficult to titrate doses with diclofenac suppository since we have an IV line. So IV diclofenac is preferred.
As far as this, Dr. Priyal, the fasting and feeding guidelines are concerned, so it is highly recommended that the guidelines given by ISA, they should be followed in letter and spirit, whether in institute or in the practice. So can I just read from your side what you are following for pediatric patients?
Sir, as I said that mostly we are following an NPO of 4 hours. So advising milk to the child. Now this age group mostly is on breastfeed. So whichever child is on breastfeed, I mostly advise to give breast milk 4 hours before surgery. And yes, sir. And as I said that till now I have not, and I try to follow these NPO guidelines. But till now, sir, with the 4 hour NPO, I have not encountered any aspiration problems. And it helps because the child starts feeling hungry very soon. And the parents, they have that fear that we have not given anything to the child for so long. The child is crying, the child is apprehensive. So it is important that we maintain minimum NPO status as much as we can.
Yeah, as per guidelines, for a woman, 4 hours is sufficient. So there are some more questions coming up.
Yes, sir. Dr. Madhuri has asked, can we use ketamine if patient has history of convulsions?
No, I usually avoid ketamine in patients with history of convulsion. It can raise ICP, and in children are very prone to convulsions. Slightly raise of temperature may lead to convulsions. So it's better if we avoid ketamine. So that is why a proper history is important in PAC. So if there is a history of convulsion, mostly I avoid ketamine.
Okay. Dr. Priyal, there is one more question. In post-op period, when you allow feed?
In a normal pediatrics, in a normal daycare surgery, mostly as soon as the child is awake, crying, and the time that we have, the time that I'm giving feed to the child is mostly 4 hours post-operative. So we give a feed to the child in a daycare surgery, 4 hours post-operatively. One feed is given if the child is taking it properly, and then 1 hour later we discharge the child with proper instructions to the parents.
Okay. Dr. Deepak has asked, esmolol is used as prophylactically or used only when required?
Esmolol was used in as bolus doses intraoperatively. It was not used prophylactically. The target was to keep a heart rate below 140. So I would say it was being used prophylactically, and we did not allow the heart rate to go above 140 because that can cause problems.
Dr. Priyal, can dexmedetomidine be used in this case? There's another
I'm not aware of the safety of dexmedetomidine in these patients in the pediatric age groups. So I haven't used it in pediatrics. And this was the only study that was available regarding beta blocker use to maintain the heart rate.
All right. Regarding the diclofenac use, as mentioned by Dr. Rasit Vaishnav initially, he has mentioned that even if there is no renal or hematological problem encountered, it is deposited in cartilages till age of 11 years.
Mm-hmm.
So basically not recommended. This was about diclofenac.
Mm-hmm. Okay.
That's all.
Few more coming up. Dr. Girish wants to say something.
Yes.
Dr. Girish, unmute, please.
Please unmute yourself, Dr. Girish.
Yeah, thank you, sir. Priyal ma'am, it was an excellent presentation. I just wanted to ask you, ma'am, your patient, this particular case, indeed will be having generally pediatric people will be having upper respiratory tract infection at the time of surgery. So, what are the steps you will be taking to prevent or avoid bronchospasm perioperatively?
Yes, sir. It's very important. Pediatric patients, first of all, it is very difficult to assess what stage of URTI they are in. Most of the time at PAC, the patient will be crying. When you are assessing the child, it is very difficult to actually understand how much of the URTI is still there. So mostly history is very important. If there is active running nose, if there is active productive cough, then obviously we have to wait for a week or two, prescribe proper antibiotics, and then we proceed for surgery if it's a completely elective surgery. Emergency, obviously we have to explain the risks to the parents. Now, even after that, if we are encountering any bronchospasms in the patients, so sir, if you've seen, I'm using propofol for induction and sevoflurane. So that itself avoids bronchospasm. Also, I'm using mostly in daycare surgery supraglottic airway. So the trachea is not being handled. So that also prevents bronchospasm. Extubation has to be very careful when the child is breathing with, you can see a good chest rise and the child is breathing properly, the child is active, ready to take out the tube, then only we have to go for extubation. So in these, with this, we can handle bronchospasms. And even after that, bronchospasms are very common. I do face it in almost every 4th to 5th case. So what I use is hydrocortisone. In the doses of 1 to 4 milligram kg, mostly in 4 milligram per kg. Sometimes at the time of extubation, if the bronchospasm is very severe, I usually go for a very low dose of propofol. So that effectively manages the bronchospasm, and 100% oxygen at the time of extubation is very important. That also helps.
Ma'am, any experience in using prophylactic dose of dexamethasone overnight, madam, for next day morning surgery?
No, sir. I have not used dexamethasone prophylactically.
Thank you.
Dr. Rajiv Gupta.
Yeah, Dr. Pierre, very well managed case and nicely presented. Here I would like to share one case which I encountered. There was a child, 1 day old, normal delivery, and there was he had some respiratory distress. For that, he was put on oxygen. CT was done, and there was a big cyst in the lung, left lobe of the lung. So case was decided to get it operated. CT was okay, cardiac part was okay. And on ventilator with spontaneous ventilation on SIMV, patient was maintaining his saturation about 80 to 92%. So that was the state of affairs where this SpO2 was fluctuating. Just before the surgery, his SpO2 decreased to 48%. There was tachycardia, pulse was somewhere around 158. ABG was done. pH was 7.4, PCO2 was 79, and PO2 was 45. But then surgeon insisted that we have to do the surgery, and so we decided to get it done because we are at a setup where we have all the gadgets and everything where we can manage these cases. So we started the case. With that, we did the suction and everything to increase the SpO2, but to no avail. Then we decided to change the tube. So we did patient was on spontaneous ventilation. We assisted that,
with the bag mask ventilation, his SpO2 raised from 48 to 96. But then when we intubated, again, it dropped to 48. So we could not find out any reason why this SpO2 fall. We tried to manipulate tube, but yes, there was chest movement, but SpO2 was not increasing even with the 100% oxygen. So, but then we started the case after explaining everything to the ultimately the prognosis was already explained to the patients, parents. They were ready to get it done. So we started the case. After getting the thorax open, chest open, we found out that lung was not inflating. Only a small part of the distal lung was getting inflated. And even after that, we could not get his SpO2 raised more than 50-52%. So the reason I could not find out anybody who can suggest or who can put light on that.
Sir, bag mask, there was inflation of the chest when you're doing bag mask ventilation.
Even with the bag mask, inflation was there. With the tube also, inflation was there. But after intubation, saturation again dropped to 48 to 50%. Mm-hmm. With the bag mask assisted ventilation, it raised to 96%. Though it took time, it took a good 10 to 15 minutes. It raised slowly, but ultimately it reached 96%. But after intubation, it never reached that level. Any such case, any of us encountered?
So nothing like that.
It's very surprising.
It sounds very surprising, actually.
Yeah, see, CT was done. There was no tracheobronchial anomaly. Cardiac status-wise, the child was okay. But why with bag mask, the SpO2 was good, and with intubation, it dropped to that level. Throughout the surgery, it remained like that. It even went to 30% also. But luckily, that hemodynamics were maintained. BP remained systolic around 70-80, and pulse rate was somewhere around 154. Throughout the surgery, it remained that. But SpO2 never raised. And when the chest was opened, the lung was not getting inflated. Only a small part of the lower lung that was getting inflated. Otherwise, though cyst was big, yes, 5 by 5 centimeters, they said. So maybe it was occupying most of the lung. But then SpO2 should raise with the right lung also. Mm-hmm.
Dr. Rajiv, you have put a question. I hope somebody will answer in the chat box about their own experience. And personally, I think this is a very peculiar issue. And finally, what happened post-operatively?
Post-op patient was shifted on ventilator to the nursery. And the status is same. Okay. One more case, the next day, this was on Sunday. On Monday, I had to get a case operated that was for fractured D9. Patient had fractured ribs, 3-4 ribs are fractured, mild hemothorax, mild pleural effusion. Patient was taken to OT. Cardiac status was okay. Again, the same thing happened. He was intubated and the saturation dropped to 70%. He was nebulized. Bronchoscopy was done, everything was clear, but his saturation remained 75%, 80%. It never is beyond that. Patient was then extubated. Again, on ventimask, his saturation was 100%.
So any problem with, sir, on a lighter note, pulse oximeter check kar lete hain, sir.
No, sir. Any problem with
it was in different OTs.
Sir, any problem with oxygen supply? Because with bag mask we can get the air also.
We are working in 7 OTs, and the same central supply is going to each OT.
Good.
So
Right.
there was no issue about that. Secondly,
Okay.
these two cases which I'm telling you, they were done in different OTs.
Right.
So even that issue I
Because-
thought of, but it was not there.
Both the time you are getting good saturation with bag and mask, and with after intubation it is
with
falling.
intubation,
That's why I am.
And you will refer the patient to pulmonologist. He is working out. Let's see what happens. Then I'll share the things.
Because
Yes.
say what's happening, Dr. Rajiv, is that as soon as you intubate, that means the airways may be hyperreactive and they are going into some sort of spasm. But you already said that you have ruled out obstruction, kinking, and you ruled out the spasm of the airways, and maybe some nebulization and all those things must have they have been done.
Definitely, everything was done.
They're absolutely sure that you must have done all the maneuvers. So,
Yeah.
Any allergy or eosinophilic count, baseline eosinophilic count? Because just go for that. Just go into that thing also about the eosinophils. Like to have Nishant also coming in here about the eosinophils. Nishant, because at times, Dr. Raji, what I've seen in one or two cases is everything is normal except raised eosinophil count.
Yes, but DLC was
Just have a complete hemogram done.
visit. But as far as now, I have seen TLC and DLC eosinophil counts were normal.
Okay, so I'll invite Dr. Sharma. He wants to say, and please unmute yourself, Dr. Surinder Sharma.
In this, I don't know. It's a very peculiar situation which has no simple answer. But what I feel is that probably it can happen at the machine level where the circuitry of the two is different. So that when it comes to intubation and closed circuit, then it is different, and when it is open circuit, then it's different. So then there may be a mix-up in the oxygen level between the two.
So we are doing cases on that machine, and after that also we have done 5-6 cases, but nothing happened. So that part, I think
you had these cases now recent this thing, right?
Sunday and Monday, yes.
Right. And secondly, the kind of patients you have, some of us can live on 21%, others probably cannot. So that may be one of the reasons that others did not have this kind of problem. So machine probably, it's just a speculation, needs a little checkup and assessment of oxygen supply between the two levels.
So basically, Dr. Ajit, see, everything has to be looked into, and I'm very sure that you're doing that, whether it is the machine or the equipment or the patient himself. And once you are there, I'll request you to present this case, not as a chairperson, but as a speaker. So we'll look forward to your presentation in due course of time.
Definitely.
And
Definitely.
Thank you very much. And I think, Dr. Himanshu, if you want to say, please, you raised hand. You can unmute yourself and express. In the meantime, Dr. Neha, there are certain questions about fasting. So I'm projecting our own ISA-IJ guidelines about the pediatric fasting and feeding. For the benefit of the house, if you can just read it down, that will be absolutely fine. This is the pediatric section I'm projecting. This is the adult, obstetric, and this is the pediatric one. Okay?
Yes, sir. So in the pediatric section, as stated by the Indian General Anesthesia, the guidelines by the ISA, there is a strong evidence that the consumption of water up to 3 ml per kg should be allowed until 1 hour prior to administration of anesthesia. Consumption of water up to 3 ml per kg should be allowed until 1 hour prior to the administration of anesthesia. There's a weak evidence supporting the consumption of clear liquids other than water up to 3 ml per kg can be allowed until 2 hours prior to the administration of anesthesia. Human milk and fully skimmed non-human milk can be allowed until 4 hours prior to the administration of anesthesia. It also has a weak evidence. Non-clear liquids, non-human milk, and non-formula feeds. Sir, can you scroll it down? No, sir.
You're not audible, sir.
Hello.
Non-clear
So that is
liquids.
yes, sir. That is all non. Yes, sir. So I'm not able to read the next line. It's not visible on my screen.
Okay, I'll read it down. Non-clear liquids, non-human milk, formula feeds, light breakfast or light meal may be allowed until 6 hours prior to administration of anesthesia. The attending anesthesiologist can decide for or against the administration of aspiration prophylaxis in adequately fasted fasted children. The attending anesthesiologist can decide on the duration of the fasting or procedural sedation within operating room or at remote location. And the oral consumption of clear liquids in the post-operative period should be resumed at the earliest where no medical or surgical contraindication exists. So that will answer 2 to 3 questions which have come up in the chat box. And so that there are certain questions which are there in the chat box which can be taken care. And I think if final round for Q&A, if there are any more questions, we can quickly. Human milk is 4 hours, sir. Milk, Dr. Ashish Vaishnav had raised that question 2 to 3 times. Sir, the guidelines clearly talk about different types of milk preparations. I'll project it again. And so this is there. This is published in our Indian Journal of Anesthesia also. So when we talk of milk, it is human milk and fully skimmed non-human milk, which is 4 hours. Non-human milk, formula feeds is 6 hours. I think that will answer the questions on the fasting and feeding. And then I think we are almost done. I'll request Dr. Priyal, because of paucity of time, you please reply to the questions if they are left, so that we can move on to the next speaker. Please reply if some questions have not been answered. Just see in the Q&A.
Sir, one question is regarding prophylactic derifylline if emergency surgery in case.
So please reply in the chat, type it, so that because we're getting late, so okay, we can start with the next presentation.
Before the next presentation, please allow us to introduce our next presenter, Dr. Vijay Prakash Tyagi, sir. Sir is a consultant anesthesiologist at Ganesh Super Specialty Hospital, Dwarka Pain Clinic, Dehradun. His major achievements include LLB, assessor at NABH, and vice president at IMA Dehradun. And his area of interest includes pain and medical legal cases. We welcome you, sir.
Good evening, everyone. I'm a bit nervous after seeing such a great speakers and the panelists. I'm a freelancer anesthetist, and my presentation is specially meant for the freelancer anesthetists who run here and there for the short duration of cases. And these 2 cases which I am going to present, these incidents happened with me only. So, a case of the perioperative pulmonary edema. And this was a case of 65-year-old female, known case of IST, medically managed, and was taken up for the laparoscopic cholecystectomy, PSC done, and the cardiac risk stratification done. Induction was done, general anesthesia was administered with the premedication, glyco, fentanyl, ondansetron.
Dr. Vijay, I would just like to interrupt. We can't see your slides, sir.
It's a minute. Still not visible?
No, sir. We can just see your
screen.
window on the screen.
Not
Please
visible.
open your presentation on the screen, sir.
I have opened and slides. Can we see it right now, ma'am?
No, sir.
Just give me 1 second. I need help. It was okay. Just 1 minute. If I can present next after the next speaker, then I think it will be okay.
No issues. Sushil, Dr. Shashi, please introduce Dr. Sushil.
Yes, sir. We welcome Dr. Sushil Kumar, sir. He's a senior consultant at anesthesiology and critical care, quality head at Parmar Multi-Speciality Hospital, Rupnagar, Punjab. His major achievements include founder of IILSS, International Institute of Life Saving Platform of Learning, platform to learn CPR skills. Online CPR courses, people from 75 countries joined and developed a low-cost ventilator with the collaboration of IIT Rupnagar. He has got more than 20 publications in reputed international and national journals. He's a co-author in a book on back care. Rotatory Vocational Services Award from Ethical Practices in the Field of Medicine. His area of interest include cardiopulmonary resuscitation. We welcome you, sir.
Thank you, ma'am. Thanks. Yeah, ma'am. Is it visible, ma'am?
Not yet, sir.
Okay.
Yeah.
Now, ma'am?
Yeah,
Yes,
it is
sir.
visible. Thank you very much.
Yeah. I remember a few years back, this person came to PAC room and he was held by two persons. I made him sit on the chair. And the moment I asked the first question, he said, I'll not be able to speak because of breathlessness. And you just talked to my brother on the phone. He dialed one number. And at the same moment, he started snoring. He slept. I talked to his brother on the phone. And his brother said, so this person is bedridden since 3 years. And he lost his job. And he had 2 life-threatening accidents while riding on the bike because he slept while driving. Today, I'll discuss the anesthesia management of this patient for a bariatric surgery. This is a 34-year male patient. And before this, I would like to share being working in a peripheral hospital. There are few challenges that we are facing. We don't have a pulmonologist in our city. And luckily last year, one cardiologist settled at our place. We don't have FOB. We don't have regular supply of fentanyl. Intermittently, we are getting it intermittently. And definitely, we are having financial constraints. In PAC, this patient was having hypertension and diabetes. We optimized these conditions. And in bariatric anesthesia, we always write 2 weight. One is actual weight and another is lean weight. Lean weight is 120% of the ideal body weight. And how do you know the ideal body weight? If you subtract 100 for male and 105 for females from the height, the patient's height is 165 centimeter. And so his ideal weight is 65 kg. And if I multiply the 1.2 to his ideal weight, it comes 78 kg. So his lean weight is 78 kg. And actual weight is 164 kg. And his BMI was 60 kg per meter square. So he was super morbid obese patient. And lean body weight is important because we give most of the drugs according to the lean weight, not according to the actual weight. This patient was having good venous access on the right dorsum of hand. And if you don't find venous access, then peripheral venous access, then go for central venous condition in this type of patients. In airway assessment, he was mulnopathy class 3 and neck circumference was 46 centimeter. Mulnopathy class 3 or 4 and neck circumference more than 43 centimeters. These are the two most important clinical predictors for difficult intubation. Now comes the investigations. His routine investigations were near normal. His ABG has shown hypoxemia and hypercarbia. And in sleep study, he was having severe OSA. AHI was 55. We sent this patient to a tertiary care hospital 30 kilometers from our place to evaluate the cardiac status. And his stress echo was normal. In preparation, two things are very important for bariatric patients. One is incentive spirometry and another is BiPAP. We motivated him to do the incentive spirometry as much as he can, at least 6 times a day. And overnight, go for BiPAP as per sleep study. So at the daytime, we tell patient to do incentive spirometry as much as he can. And at nighttime, go for BiPAP. These two conditions, these two preparations really take care of OSA. So we optimize the patient before surgery. Patient was admitted a day before surgery, and we gave 3 prophylaxis: aspiration, DVT, and antibiotic. In OT preparation, we did as per MS Mates mnemonic. S stands for special, and first special thing is OT table. We have a special OT table for bariatric patients whose capacity is 350 kg, and it's wider than usual OT table. And we also use DVT pump, fluid, and body warmers. And we checked our difficult airway cart. We applied standard monitors. And during NABP, always take the BP cuff of that size. The bladder is at least covers the 75% of the arm of the patient. Ideally, it should cover the whole circumference of the arm, but at least 75%. Then we wheeled in the after wheeling the patient on the bed in a head-up position, we started pre-oxygenation in the head-up position only. And we created ramp by putting the folded sheets below the shoulder, neck, and head. And the end point was the chin should come above the chest. I repeat, the chin should come above the chest for intubation for bariatric patient. And we did pre-oxygenation until saturation reaches 100% and remains so for 3 minutes. And ideally, we should 2 anesthesiologists at the place. And we were 2 at that time. And in our hospital, we had 2 anesthesiologists. Then we gave injection butyrophenol 2 milligram, propofol 240 milligram, and Saxa 150 milligram after confirming ventilation. 8 size ETT was secured and ET suite was connected. For maintenance, we use sevoflurane and atacurium. Whenever saturation started decrease, we used to do alveolar recruitments. How do we do? We take the patient on the manual mode and close the APL valve till 40 centimeters of water. And we do sustained inflation for 30 to 45 seconds. And it's really a very good, effective method to raise the saturation. And mini gastric bypass was done for this patient, and it was lasted for 2.5 hours. And we gave 4-liter fluids for this duration. And during surgery, Uji was advocated to guide for the sleeve. And for that, 2 things are necessary. We should lubricate the bougie. And the second, while doing leak test with this bougie, always make sure the ETT cuff should be tightly sealed. Otherwise, the methylene blue that we use in the leak test, patient get aspirated. For pain management, surgeon used to give 2% lignocaine at each port site as preemptive analgesia. And we use paracetamol 1.5 gram and charted and 6 hourly. And we gave ketorolac 45 milligram and charted 2 times a day. After giving reversal, we extubated the patient only in head-up position when the patient is fully awake. Before surgery, incentive spirometry and BiPAP are the two cardinal things that we should take care of. And during intra-op extubation, when the patient should be fully awake and it should be done in the header position. Then we shifted the patient to the recovery room and we started BiPAP for 2 hours so that all the residual effects of anesthetic agents should be weaned off. And after 2 hours, we shifted the patient to a special room in ICU. And in the same evening, we started incentive spirometry and patient was ambulatory. And overnight, BiPAP was put and it was continued for another 3 weeks. So pre-op BiPAP for 1 week and post-op for 3 weeks. Total 1 month package for BiPAP. And DVT prophylaxis was continued for another 7 days. Next day, the patient dye test was done and it was normal. And 4th post-op day, patient was discharged. And after 20 days, patient's OSA was significantly improved. And after 4 months, the medicines for blood pressure and diabetic were stopped. And after 9 months, this person became like this lean man and fit man, and his weight reduced to 84 kg. It's really truly gratifying to witness the patients of these morbidly obese patients to regain their health and to overcome the obesity-related complications and just live their life fullest. Thank you very much. Now I would like to share the link to our bariatric anesthesia protocol. You please check in the chat box. It's there. Thank you.
Yes, sir. It's there. Thank you very much, sir. It was a very interesting presentation. Dr. Vijay, now we invite the chairpersons
Yes,
for the
ma'am.
questionnaire.
Dr. Sushil, nice presentation.
Thank you, sir.
In your bariatric anesthesia practice, you mentioned around 10 years. It is a peripheral hospital, I understand. Is it a peripheral hospital? Yes.
Yes, sir.
So, what special airway gadgets you have in your hospital?
So we are managing with, we just 1 year back, we purchased this video laryngoscope. Other than that, we don't have anything. We are just managing with the oral airway and bougie, these 2 things.
Oh, wonderful.
Till now, we haven't faced any problem in a single patient. Ventilation, oral airway, and for intubation, bougie.
Very nice. And do you follow ERAS guidelines on bariatric surgery?
For anesthesia, sir?
Yes, yes. For surgery and anesthesia, yes. Like glycemic control, weight loss before surgery.
Yes, sir. Yeah. We're doing that.
And smoking should be stopped.
Yes, sir. Yeah.
One of the doctors has a question that can you please explain it again, the alveolar equipment?
Yeah. First, we take the patient on the manual mode. We switch off the ventilator mode and take the patient on the manual mode. And then set the APL valve at 40 centimeter water. And do sustained inflation for 30 to 45 seconds. And it raises the saturation. Am I clear?
Yes, sir.
Dr. Sushil,
Yes, sir.
I have a suggestion. If you are
Yes, sir.
regularly doing bariatric surgery, then it is my personal advice. Maybe it is you are very fortunate and you are very lucky that you didn't had any problem in intubating all these patients over last 10 years without fiber optic. It is my personal suggestion that without fiber optic, we should not proceed with bariatric surgery. Recently, I had a patient she was very lean and thin, and I didn't anticipate any difficult intubation. And in that case, finally, I had to postpone that case because she had a very difficult anterior larynx and it was difficult to intubate. So I had convinced the attendants that we will take her tomorrow morning because she needs fiber optic intubation. So it is maybe we are lucky 100 times, but maybe it is 101, then we can get stuck. So if you are practicing for practitioners, I will say you can increase the charges, you get it done, you purchase one fiber optic, it will definitely be of a great help.
Okay. Right, sir.
And the things are very smooth unless it is smooth. Because a person who is so obese is financially obese also. So the litigations are to be very high. So please take care because nowadays we are facing litigations many times. So if in the court of law, we have to prove that we had all the gadgets. Don't depend on others. Please raise your charges by 5,000 per case. It will recover your cost very soon.
Right, sir. Thanks.
Because it is for private practitioners. So I also bought it recently, and touch wood, I have recovered the cost also because I am doing the cases which are postponed from all the centers because of difficult intubation. So I took 20,000 for a case which was postponed at 4 centers because of difficult intubation. So please take care, sir. That is my personal suggestion.
Thank you, sir.
Not only procuring not only procuring the equipment, but getting trained in using those equipment is also very essential.
Yes,
For peripheral anesthetists, they have to put extra, interest and time to get trained in these.
Yes.
By attending workshops and all.
Because the learning period is really
it
takes a lot of time. Because I used FOBs sometime when I was PGI, but it's learning curves. It's so long actually.
I also do some bariatric practice, but most of the times we prepare very well so that we avoid difficult situations. But sometimes it happens.
Yes, sir, I agree.
Yes. So sometimes I felt, intubation is very easy than a normal patient also because we prepare very well. Right. Thank you.
Yes, sir.
Yes, sir. There is one more question in chat box. Can you please elaborate about the initial as well as intraoperative ventilator settings?
Yes.
Okay. We keep the tidal volume around 400 ml and the respiratory rate is around 12 per minute with PEEP 5 and I ratio 1:2.
I think, Dr. Sushil, we need to put some more PEEP in such cases.
Yes, sir.
5 is not sufficient most of the times.
Okay.
This is my personal observation that 5 PEEP is not essentially when the patient is 100 plus kg. So we need to have 6 or 7 PEEP for such patients.
So 5 to 7 I used to
up to 8 also.
After that there is always it's maintained with 5 to 7 actually.
Although you are doing lung recruitment techniques, you are doing maneuvers, you are doing it. But for a long-term case where you have you are anticipating patient is already breathless and on BiPAP support. So intraoperatively we need to do it. And I don't know if you are using ABG as a parameter.
Yes, sir. We're doing ABG.
Yes, that is one more important thing. You should get a baseline ABG done so that you have the with the OSA patients we must have PCO2 levels pre-operative.
Yes, sir. We always do.
Thank you very much.
We have a question from Dr. Anamika. Dr. Anamika, please unmute yourself and go ahead.
Yeah, unmuted. No, sir, just I wanted to ask, like you told you are taking a pediatric. So if you ask your center to get pulmonologist, so what I did here in our center, pulmonologist we asked. So for pulmonologist, they brought fiber optic bronchoscope. So our work got it done. Like they didn't want to purchase for anesthetist. So they bought it for pulmonologist and we were using like fiber optic bronchoscope. Just for security, we never know when we'll end up in problem, right? So that is one suggestion. And second thing, because pre-op PFTs and all we can do, and post-operatively, we can't take whole soul responsibility, right? Post-operative, if patient goes on, so pulmonologist will take care. So we can be little, relaxed. Like once you shift to ICU, so it should not be only our responsibilities. If you add on the other specialties, that is always better, sir, right? And intra-alveolar recruit, you told, so same thing. PEEP, I have used up to 8 also. If BP is maintained and all, because when I do neonatal surgeries, I do like sometime preterm neonates and all. If saturation is not maintained, we increase. Sometime I use that neo puff only, like not on ventilator. So with that, we increase, from saturation will increase. Rather than taking the patient on manual mode, we can increase the PEEP, and if BP is maintaining, it is always better. So we can keep up to 8 also I have used. So I just wanted to suggest you. Yeah. Yes, sir.
Thanks, ma'am.
Yes, sir. Thank you, sir.
Thank you.
Thank you, sir. I think we can move on to the next speaker.
I think just add one point in Dr. Sushil Kumar's intraoperative strategy.
Sorry, sir.
Can I, with the permission of the chair, can I add one little modification in bariatric patients' ventilator strategies? As we can think of giving pressure control ventilation, which is better is in case of obese patients. So we can start with PCV. One more thing, which obviously with the PEEP and tidal volume. Tidal volume which we do is on ideal body weight and not on the actual body weight. I think that is understood. But importance of IE ratio. So that's very important, especially in obese patients, especially patients who are having some amount of restrictive lung disease because of obesity. So their alveoli will take time to deflate, and probably they might need some more prolonged respiratory time. So apart from all this which have been discussed, I think IE ratio also should be kept in mind while ventilating this patient. So PCV and IE ratio, I think that 2 addition from my side. Thank you.
Thank you, sir.
I think we can move on to the next speaker now. All the questions have been answered. Over to you, Dr. Shashi.
Dr. Vijay Tyagi, sir, are you ready, sir?
Yes.
So we welcome you for your presentation, sir.
Yes.
So please select the presentation on your desktop, then it's going to be visible on the whole screen.
It's all good. You move to the next slide, please. It's all good.
Okay. So I am a freelancer anesthetist, and my presentation is especially meant for the such anesthetists who are running here and there for the small short duration cases. These 2 cases happened with me only. The case of perioperative pulmonary edema. This was a case of 65-year-old female, known case of IHT, medically managed, was taken up for the laparoscopic cholecystectomy. PAC done and cardiac risk stratification were done. Patient was induced with the premedication, glycopyrrolate, fentanyl, and ondansetron. Induction was done with the propofol and atracurium. General anesthesia, IGL was number 4 was introduced. Placement confirmed, and maintenance of anesthesia, isoflurane, oxygen, air, and injection atracurium. Reversed with the glycopyrrolate and neostigmine in the recommended doses. On complete recovery and adequate reversal after thorough suctioning, IGL was removed. On removal of the supraglottic airway, the patient started having difficulty of breathing and she started desaturating. SpO2 went down to 80% and patient also developed hypotension. BP was around 70-40 mmHg. Patient was immediately intubated again with the 7.5 mm ET under direct laryngoscopy, tube placement checked, and ET CO2 and auscultation. On auscultation, bilateral capitations were present on all over the lung field. Pink frothy sputum was observed in the ETT. Injection norepinephrine was started immediately. Injection Lasix 60 mg IV stat was given, and once the blood pressure was stabilized, ABG showed respiratory acidosis with the PaCO2 of 80 mm of Hg. Patient was shifted to medical ICU and was managed on the mechanical ventilator with the PRVC, tidal volume 6 ml per kg, PEEP 6 and FiO2 of 100. Immediate cardiology opinion was sought and bedside transthoracic echocardiography was done, which suggested of the jerky IV septum, LVEF 30%. ECG shows signs of onset of left bundle branch block. X-ray chest, sign of pulmonary edema. Trop-I was negative. Patient was managed in the ICU with the diuretics and morphine on mechanical ventilator. ABG later in the day improved with the pH 7.43 and PaCO2 and PeO2 became normal. Lactate was normalized. Trop-I 6 hours later was again negative. Next day patient was weaned off mechanical ventilator and observed for 24 hours and shifted out. The causes of perioperative pulmonary edema can be cardiogenic pulmonary edema, neurogenic pulmonary edema, the fluid overload, anaphylaxis, acute lung injury, and the negative pressure pulmonary edema. I've seen this negative pressure pulmonary edema in 3 cases of mine. Fortunately, patients were saved. This is again a new case. Judgment was delivered on the 6th of this month. P. Thomas versus Dean Hospital NCDRC judgment. This is the same case almost. 2000 case, negative pressure pulmonary edema after GA for laparoscopic tubal ligation. Patient though died and compensation of about 7 lakh were awarded, but NCDRC dismissed this whole case. Fortunately, just because of anesthetics, I think. This was the second case of obstructed apnea in the PSU. A 28-year-old patient who was a medical officer himself was taken up for the shoulder arthroscopic repair. PSC was done, it was ACA grade 1, GA was given, and the surgery lasted for about 4 hours. Patient was extubated successfully, and because of upcoming neck surgery in the OT, next surgeon was asking, we have another case lined up, you are already delayed, please, fatafat. So patient was shifted bit early to the PSU. And patient was bit sedated also, but following verbal command. He was not in the deep sleep kind of thing. After about 5 minutes, a SOS call was given to me. Patient was attended immediately. I was in the changing room only, or in the lounge. The patient immediately became cyanosed, pulseless, non-recordable blood pressure. CPR was started, intubated, pulse as aspiration became palpable and spontaneous. ABG was sent previously, and it showed again the respiratory acidosis with the PaCO2 of 85. Patient was connected to the ventilator and hyperventilated for about 30 minutes. Next ABG was normal. Later on, he was successfully extubated and discharged next day. So, cause of respiratory obstruction due to tongue fall leading to the respiratory arrest was the scenario. Was just because the proximity of anesthetist or the expert, we were able to save that patient. The complication in PSU, it's a common practice for the most anesthetists who receives, for patients who receive GA, regional anesthesia, MAC, to be monitored in the PSU. Medical oversight of the patient in the PSU is a responsibility of anesthesiologist. Post anesthesia care is a part of anesthesia, and any breach in the care is considered as negligence. If this duty of the care is delegated to other than the anesthesiologist, is vicariously liable for that. Or if we are delegating this duty to someone else, that he should be the competent person. Only then we can save the life if such kind of complication occurs. The common complication in PSU is anesthesia related, different complications of general anesthesia and in the regional anesthesia. Again, duration of the surgery, short duration surgery and long duration of surgery, age and sex of the patient. Female patients are having more complication in PSU because of the different reasons. Surgery related, elective surgery and the emergency surgery. Most frequently encountered PSU complications are respiratory, desaturation, stridor, wheezing. Cardiovasculars are hypotension, hypertension, tachycardia, bradycardia. Post-operative nausea, vomiting, aspiration, temperature, hypothermia, pain, and CNS-related adverse events. Duty of anesthesiologist does not end with the safe extubation only, but extends up to the safe transfer out of the patient from the OR to PSU. Immediate post-operative period is very prone for the complication, but manageable if attended by the competent staff or anesthesiologist. Good monitoring in the PSU is necessary and can save the life. There are innumerable number of the cases in the post-operative period where the anesthetist thinks that his duty ends after the patient shows the tongues or follows the verbal command, and the complication occurs in the post-operative period. Especially when anesthetist and the surgical team moves to the different center, many cases are there where they go to the periphery, operate, and after leaving that center, we hear that there is a tongue fall or anything, desaturation, and there is no competent person to attend that patient, and we can lose that patient. So it's a pure responsibility of anesthetist in the post-operative period. If you are delegating our duty to someone else, that person should be competent enough. Thank you.
Thank you very much, sir. We now welcome our chairpersons for the discussion. Dr. Sunil, sir.
Thank you very much, madam. We had a wonderful discussion today, and it is the normal response of the participants that even with 4 speakers, we are falling almost short of time.
Yes.
And starting with the stress cardiomyopathy and peripartum cardiomyopathy, I was the anesthesiologist at Dr. Naveen's wife's center. She is a practicing gynecologist. I have witnessed peripartum cardiomyopathy, and we did a case 24 hours back, and next day we had this problem. Recently, I had a patient with 1.5-year-old posted for adenotonsillectomy, and the patient went under adenotonsillectomy. She had, that baby had tongue edema and edema of the uvula, and there was a pack in the nasopharynx also. So that patient developed hypoxic convulsion also on the table, even after putting a IG. So perioperative care has to be taken care very enormously. As Dr. Tyagi has said, we can have so many problems we need to address. And long back, when once I remember, our teacher used to tell, when we were using halothane, although halothane is out of date, but that used to cause halothane hepatitis. So we are not done with 24 hours. We are liable even after 30 days of anesthesia. If I am wrong, academicians can correct me at any time. So, and the patient, from Punjab, obesity. He was talking about obesity. We have so many problems in patients who are very obese. We need to check their bedside pulmonary function test. We need to test them for the post-op respiratory reserve also. The thing is, we are not finishing with just as Dr. Tyagi said, the patient is protruding tongue and he's pink. We have seen patient having pain and somebody giving analgesic, and that too sedative in an obese patient. And once the patient is sent from OT to the ward, he lands up with respiratory depression, either because of the residual effect of the muscle relaxant or because of the overdose of the opioids used during the surgery. So we have to be very cautious. That's what I wanted to add. Thank you very much.
Dr. Tyagi, you nicely described the position of the private practitioner. Normally, we are leaving as early as possible to attend the other case. And I think almost all anesthesiologists have faced reintubation, pulmonary edema, and all these things once or for so many times. So you are absolutely right that our duty is not finished only after showing the tongue, but to keep the patient on proper hand. And I think institutional peoples are more beneficial in that side compared to our private practitioner. And we have to take care as much as possible in this medical legal era. So you nicely described all these things. Great.
Dr. Tyagi, I must congratulate you because you have brought out the things, the complications faced by you in the post-anesthesia care unit. And usually it is difficult to highlight such cases. But yes, the monitoring and the eternal vigilance should continue in the perioperative period, starting from PAC till the patient is shifted out of the hospital. Thank you for highlighting those cases. And
I would like to ask this question, sir. Whether criteria-based discharge would be better to follow or the time-based discharge to follow in the PACU units?
Couldn't understand what you mean.
Like we use the Alred criteria-based discharge that we follow.
Yes.
So
Yes.
According to you, we should transfer the patient according to Alred, or we should use the classic time-based discharge criteria that we normally follow for 1 hour? Because with the long number of surgeries that are happening, like in Apollo Hospital, what we face is we have 6 OTs in one complex, and we have got 1:1 bed only in the PACU unit also. So that is causing a bottleneck because large number of surgeries are happening, but the patient is not getting shifted from the PACU. So that also causes.
So that is the difference between the institutional practice and the private practice. That is why this forum selected the private practice. See, in institution or corporate setup, you have very good trained nurses, and you can follow modified alternate score and everything. But in private practice, the practitioner cannot stay until 2 hours, 1 hour until everything goes well, because they see especially the muscle relaxation is recovered or not, patient is awake or not, and then they will go to another hospital. I think that is the thing.
Yeah, that was what Dr. Badresh was also highlighting. But still, Dr. Badresh was categorical enough that even if we are in private practice, we should ensure that patient is safe and can be managed in that particular setup. And
I have my 1 or 2 surgeon friends specially arrange tea and breakfast after the surgery, not just to feed the anesthesiologist, but because of that, anesthesiologist stay 5-10 minutes more in the OT. So patients stay nicely. So he said every time he is saying that I am always keeping breakfast or tea and everything, just because anesthesiologist should not run away immediately. So he is using this technique.
Not only surgeons.
Surgeons should learn this technique.
This is age-old technique. We also stay by having tea or something and just passing some time. Like. Yes.
So you always demanding that thing after finishing the surgery only.
So I was very lucky that I was an anesthetist to Dr. Aki Malhotra, and even after induction and after extubation, I used to have tea and biscuits and all the luxury from Dr. Naveen. It was a pleasant working with Dr. Aki, wife of Dr. Naveen.
Great. Good. Right, sir.
Dr. Ketan Shah has got a question, sir. Yes, sir.
Shashi ma'am, I just want to add that L-right score is shifting of the patient from the PSU to different unit. It is not the score which we use of shifting patient OT to PSU.
Yes.
From PSU, once you have achieved the L-right score, you can shift it. It's not a time-based. There is a scoring pattern. Thing is, what I want to say is that there is a early post-operative complication just after shifting the patient from OT to PSU. And we have to prevent them and we have to take the responsibility of that only. Once the patient successfully achieves the L-right score, he can be shifted to anywhere.
Yeah, Dr. Tyagi, you are categorical enough to say all these things you highlighted. That the immediate management on the OT table before shifting the PAC2, so that you do not encounter any problem in PAC2. And you highlighted that surgeons was insisting on the next case to be done early. And these are the lessons learned. And there are some tips and tricks also. And absolutely fine. Dr. Hital Shah?
Okay. Yes, sir. Yeah, so Dr. Vijay Tyagi has very rightly pointed, and especially because this is the forum of a private anesthesiologist, and a lot of been told that corporate practice is a different practice. But mind you, I think I work in corporate, and the problem lies the same. I mean, we say in Gujarati, the kagda bade kada jo. I mean, straws are black at all places. So,
sir, please repeat. Sir, please repeat.
Pardon?
Please repeat, sir. I couldn't listen.
કાગડા બધે કાલા હોય છે, કાળા હોય છે.
Dr. Bhadresh?
कौवा हर जगह पे काला ही होता है, मतलब. So
सही बात है.
Problem remains the same.
Crows are everywhere black. He's saying that.
And very few are lucky, like Bhadresh bhai, whose surgeon is feeding him. But yeah, I mean, jokes apart, but I think what you have said is very, very, very important and to be learned in this medical legal era is that, just the patient is opening eye and showing his tongue or her tongue and then you vanishes from the scene is not the scenario nowadays. And I think we need to be really, really careful about it. And the good part is that in your presentation, Dr. Vijay, what I found is that you have highlighted all the points of all the causes of perioperative pulmonary edema. So that was something. So let's say in your case, it was a cardiac patient. So most of the time, people think that it's a cardiac issues which has caused into the pulmonary edema, maybe LV dysfunction or MR or something. But it's not that. There are so many other factors which is equally responsible for post-operative pulmonary edema, and it was nicely highlighted. I must appreciate that. Thank you.
And Dr. Hital, continuing on that, last week only we had this discussion by Dr. Giri from Odisha that are the guidelines not to be followed in practice. So yes, what you're saying that crow is black everywhere. So we have to follow guidelines in letter and spirit as maximum as possible. Yes, there are certain challenges in practice. That is why this P20 series is there. That when people are working individually, how they are managing with their exceptional skills, single-handedly managing the complicated cases. So, heartiest congratulations to you, Dr. Tyagi, for bringing in the problems which you faced in the OT because of early shifting to the patient from OT to the PACU. If the patient would have spent some more time in the OT in the immediate post-operative period, probably these complications would have been avoided. Dr. Sethi, you want to say something?
Sir. Before thanking all the faculty from Private Practitioner Forum, I will say we have been talking about PSC charges. We have never talked about post-operative charges. Sometimes you need to spend a lot of time, and we are not talking about the monetary benefits. But the thing is, if you get a surgery done, you have to extubate even after 72 hours. So you have to be there. Dr. Badresh, am I right?
Yes, sir. Agree. I agree.
So if you are doing a laparotomy and you're shifting to ICU, you have to be in touch for 72 hours to 48 to 72 hours for post-surgery extubation, especially in laparotomies. So that charges have to be included in your fees. So please ensure, since it is a private practitioner series, so we have to induce that also.
Yes, sir.
And thank you very much. Sir, Dr. Vijay Tyagi, sir, I came to know about your vast experience in medical legal cases. We will need your guidance. And it's a pleasure to have you as a faculty in KAP series. And next month I am visiting Dehradun. I will seek your blessings.
Actually, sir, what case happened with me, there was a DOT. So I had a different kind of experience in the police station. So after finishing that case, I decided I must do LLB. And the next day I joined the LLB and did it.
Sir, I had discussion with Dr. Parul also. It is wonderful knowing about you. We have plenty of legends in practice, in private practice.
Yes.
So you are one of them. Congratulations, sir. And it was lovely interacting with you. Thank you.
Thank you, sir. Thank you, sir.
And Dr. Priyal also, if she is there. Priyal? She has left. And hats off to Dr. Naveen for his vision. Take care, sir. And word of advice from you.
There are some, Dr. Ashish Vaishnav have complimented Dr. Tyagi, and he has highlighted that most of the immediate complications are pertaining to airway and the pulmonary complications. Dr. Tyagi, I must say that I am a son of a lawyer, and
I know, sir.
I always love people wearing black coats. So now you have got, though you are not legally allowed to wear both black and white coats, so but still, my love for you increases further because you are an anesthesiologist and with a legal background also.
Thank you, sir. Thank you, sir.
So we are coming to the end of the session. Before I hand it back to the coordinators, I thank all the three chairpersons, Dr. Rajiv Gupta, Dr.
Reddy,
Dr. Ramakrishna Reddy, and Dr. Badresh, for excellently managing the session, and to Dr. Sethi and Dr. Shashi for being the coordinators. And we'll see you soon for the next session.
Thank you very much, Dr. Naveen. Thank you, Dr. Naveen and Dr. Shashi, being co-coordinator for this session. I will request you that please bring all the practitioners from all the corners of India so that we can have a positive discussion. And it was so encouraging that we could finish 9 presentations in 2 days. That took for 6 months. How can we finish conference in 3 days?
True, agree.
Badresh bhai, 3 दिन में conference कर देते हम लोग national.
सही बात है, I agree with you, sir.
और 9 lecture नहीं खत्म हुए 6 घंटे में.
और उस टाइम पे मेन प्रॉब्लम 8 hours में simultaneously lecture चलता है. अपने इंटरेस्ट के 2 lecture कैसे अटेंड किया जाए?
But yes, but it was very encouraging, and it is the wide vision of Naveen sir. Naveen sir नहीं, Naveen भाई है, छोटा है. Sorry, Naveen bhai.
Thank you, Varsity, for your kind words, and thank you, Mr. Chaube from Anaesthesia TV for streaming it live in the different platforms.
I must thank you, Mr. Chaube sir, for live streaming. Thank you very much.
So we'll.
It is really memorable, sir. Naveen sir, it is really memorable experience. Huh? We all three chairperson enjoyed. On behalf of all of three, thank you to you, thank you to Sethi and whole team. And
thank
to
you,
all
sir.
Speakers and all delegates. Thank you.
Thank you.
Thank you, Dr. Reddy, sir.
For joining us today.
Thank you, sir.
Thank you, Dr. Shashi.
Thank you, everyone.
Neha. Thank you, Rajiv.
Thank you so much.
Sethi, organizing such a nice lectures. And I must say, for all private practitioners, they should charge more so that they can stay more. That is the
So next time आप
thing.
speaker हो आप.
Huh?
Next time speaker हो.
Speaker हो next time.
Next time. Yes, I will present the case.
यह जो आपने cases present किए हैं, उसको दोबारा से discuss करना पड़ेगा.
बिल्कुल. Yes. Definitely.
So waiting for a dedicated speaker, not as a chairperson.
And come prepared with answers.
Done, sir. You are always ready. We never doubt your competency.
Definitely.
You are an excellent person. Thank you.
Thank you. Good night, all.
Thank you, everyone.
Very short. Thank you.
Good night. Good night.
Good night.